Sir, Madam, Sir, good evening. Yes, that's how we start the session. Otherwise, it will become a monologue, which we don't want. Well, I hope all of you were able to reach the venue comfortably and you did not have a problem reaching here. At the outset, I would like to thank Dr. Harbans for agreeing and giving us this opportunity to hold this talk. Thank you so much, sir. It's indeed a pleasure to have you here. And also Dr. Anupam for agreeing to give the talk. And before we start, I would like to invite Dr. Harbans to the front and our Managing Director, Dr. Mahesh, to kindly come forward and felicitate Dr. Harbans and say thank you for coming in. Sir, welcome to Must and More. Thank you so much for coming. This is a small token of regard for you, sir, as a remembrance that will remain with you. Thank you so much. I would also like to invite Dr. Anupam to please come forward. Dr. Mahesh, please welcome Dr. Anupam for... Thank you so much, Doctor. Further, I would like to thank all of you for sparing time and having come over for the CME session today. Just one quick thought before we enter into the CME process and the scientific felicitations. Why we have kept the name of our diagnostic center as Must and More, I hope it is imperative to know the place we are sitting, that why we have kept it. As all healthcare providers, they are under obligation to give us a fantastic report and a very logical report so that a diagnosis can be made. But at the same time, we are in the process of giving more. We do more, we give more, and hence we get more from the hands of God. And that is a humble submission to all of you clinicians to give us more so that we can serve more, we can do more. That is the idea for keeping the name as Must and More. And as we say, happiness or smiling is a must, but laughter is more. Good food is a must, but then healthy food is more. So the point is, we should always look forward to be giving more and doing more. And without taking much time, I would just like to brief. Must and More is a proposed chain of diagnostic centers, which is led by our radiology giant Satyakiran Healthcare, where we are already running 25 centers, and we are 25 to 26 years old into the field of radiology and pathology. And we are committed to deliver quality services and quality reports, along with the special feature of customer delight. That means delight for the doctor means the best possible report, and delight for the patient means the best possible service or the best possible warmth that the patient can get while a scan or something is being done. To add to the feature, we have now the dual head gamma camera installed with us. We've already through the AERB inspection, and most probably from 1st of August we'll be able to deliver you the nuclear medicine scans, which will be headed by Dr. Anupam, who's the Director for Nuclear Medicine, formerly at Max Hospital, Shalimar Bagh. And before we move on to the clinical session, I would just like to give you a brief introduction about the speakers today. Dr. Harbans is a very seasoned and a renowned urologist, consultant urologist of Delhi, practicing in this part of the Delhi for the last 14 years with RG Stone. He has done his MBBS and MS from Banaras Hindu University, and followed by his M.Ch from Jipmer Pondicherry and his fellowship from Nadiyar. He did his senior residency from GTB Hospital, Delhi, Trans Yamuna, and remained a pool officer with BHU and a consultant urologist at Nadiyar as well. Presently, Dr. Harbans is a senior consultant at RG Stone Hospital, Pitampura since 2005, and he is doing close to 300 procedures in a month, which includes therapeutic, other procedures, and uh, surgical procedures definitely. He has uncounted laurels to his credit and has been specifically awarded by the World Endourology Society for original research in bipolar TERP. So he's a very proactive in doing health programs and community health and has contributed significantly to the community per se during the tenure of his practice, whatever he has delivered. So with this brief introduction, we'll have Dr. Harbans' lecture first, which will be followed by Dr. Anupam's lecture. The idea of keeping the talk as imaging in urology essentially means that we'll talk about the disease modality first, that what the disease is like, and then which will be followed by the different modalities that can be used to diagnose that, and which is the right modality at the right time to be used for the right disease. With these words, I humbly submit to Dr. Harbans. Sir, please come and take over the dais. We'll start the talk with you, sir. Sir, please. Can we have a round of applause for sir?
Lot of criticism from the media and from the society about the misuse of the investigations, and we should be careful not only providing the best diagnosis to the patient, but also we should avoid that criticism. So we should know the exact what we want to know from that clinical investigation. We all know that nowadays all radiological imaging, they are in fact part of like a extended examination. What earlier we were like, okay, examine the liver, examine the kidneys, examine for spleen to know whether they are enlarged. We now leave these things to the imaging. So most of the part of examination is now taken over by the by the radiological investigations. I will discuss this with the clinical situations in urology. Usually we have 4 different clinical situations in our setup. The most common is the stone disease. And in the stone disease, the usually patient comes with the pain, and initially he goes to the primary physician. It does not go directly to the specialist. So it is the primary physician. The first pain is relieved by primary physician. A first diagnosis is made by a primary physician. So a patient presenting with a flank pain. Now the flank pain has a various causes. It is not the only stone disease. So there are various causes of the. So clinician has to judge by the symptomatology, by the associated symptoms, and then by doing the correct investigation to find out the cause of that flank pain. So I will cover this first with the acute flank pain. Then many times patient comes to you with a diagnosis that I already have a renal stone. He says, I got this test done 1 year back, 2 years back, I have a stone disease, still occasionally I have dull aching pain. So what to do in those situations? The second is hematuria and renal mass. Third, I will cover the pediatric urology, and finally there is a lot of role of nuclear medicine in urology defined. I will cover up the clinical aspect of these things, and the radiological aspect will be covered by Dr. Anupam. Now acute flank pain, as I mentioned, usually a classical renal colic starting from loin to groin associated with nausea, vomiting. This is not because of a calicial stone. Usually whenever the pain happens, patient comes to a clinician, ultrasound is done, and on ultrasound a 5 mm stone in the upper calyx, and patient is informed you have a stone. Patient is happy that he has come to know that it is a stone. But actually that 5 stone in a calyx will never cause a acute flank pain. The acute flank pain will happen only when stone has come either at PUJ or it is in the ureter. So just finding a small calycial stone does not prove that his pain is because of that stone. So any patient coming with acute flank pain, if there is no hydronephrosis and only a small calycial stone, think something else. It may be a radiculopathy, sometime on the right side, rule out appendicitis, sometime even cholecystitis, the pain is radiating to back. So what are the options whenever patient comes to us with acute flank pain? The primary investigation is ultrasonography. But should we do only ultrasonography? No, it should be always combined with the X-ray KUB. Why? There are certain limitations of ultrasonography. A mid-ureteric stone, we cannot see a mid-ureter very nicely on ultrasonography, particularly in obese people. And in the first 24 hours, there is not much hydronephrosis. So on ultrasonography, we can miss that hydronephrosis. So it is always a complementary to do a X-ray KUB along with a ultrasonography. And if we compare all three, plain ultrasonography or ultrasonography with X-ray and CT, CT has a best diagnostic value. It is most cost effective. But what are the problems with CT? I will discuss that. Earlier, before the era of ultrasonography, it was the IVP, which was used to diagnose acute renal colic. And delayed dense nephrogram was the classical finding. You may see a stone, but that is now a thing of past. Then came the ultrasonography, and then we realized that plain ultrasonography is, it should be, X-ray should be done to completely investigate that patient. And then came the helical CT. It should be a helical spiral CT to diagnose a ureteric stone. The non-helical CT may miss those stones. The drawback of ultrasonography, it is operator dependent, hydronephrosis, obesity, mid-ureteric. But the advantage is that hepatobiliary system, if there is an associated disease like a cholecystitis, it can be diagnosed well with the ultrasonography, and adnexal and uterine and ovarian problems are better delineated. The CT, as I mentioned, is the best test. If we see, it is one of the most cost effective, but there is a problem of cost. It is costly, and the second problem is radiation. That now the questions are being raised over the use of CT in most situations just because of radiation. Now, how to overcome this problem of radiation and cost? The radiation, we can, in the CT scan, low dose CTs are now being recommended. And if we are specific what we are looking for, in the cases of our ureteric stone, if we use this high pitch with a thin collimation, we can diagnose most of these stones without giving much radiation. The radiation with this combination of high pitch and with this collimation is like just a limited film IVP. Now, can we avoid a CT scan? Yes, we can avoid, but after explaining properly. So